Hello everyone. So we will be starting with chapter 14 of illustrated textbook of pediatrics, that is gastroenterology. Features of gastrointestinal disorders in children are vomiting, abdominal pain, and diarrhea are common and usually transient. Serious causes are uncommon but important to identify. Worldwide gastroenteritis is responsible for um, 530,000 deaths per year, one of the most common causes of death in children under 5 years of age. The number of children and adolescents developing inflammatory bowel disease is increasing. In contrast to adults, bowel cancer is extremely rare. Now, vomiting, positive and regurgitation are terms used to describe the non-forceful return of milk, but different in degree. Positive describes a small amount of milk, often accompanying the return of swallowed air, wind, whereas regurgitation describes larger, more frequent losses. Vomiting occurs in nearly all babies from time to time, whereas regurgitation may indicate the presence of more significant gastroesophageal reflux. Vomiting is a forceful ejection of gastric contents. It is a common problem in infancy and childhood. In the box, red flag clinical features of the vomiting in child: bile stain vomit, intestinal obstruction, hematemesis, esophagitis, peptic ulceration, oral nasal bleeding, and esophageal variceal bleed. Projectile vomiting, first few weeks of life, pyloric stenosis, vomiting at the end of paroxysmal coughing, whooping cough, pertussis, abdominal tenderness, abdominal pain on movement, surgical abdominal distension, intestinal obstruction, including strangulated inguinal hernia, hepatosplenomegaly, chronic liver disease, involuntary metabolism, blood in the stool, intussusception, bacterial gastroenteritis, severe dehydration shock, severe gastroenteritis, systemic infection, UTI, meningitis, diabetic ketoacidosis, bulging fontanelle or seizures, raised intracranial pressure, and faltering growth, GERD, celiac disease, and other chronic gastrointestinal conditions. Now, the causes of vomiting in a tabulated form: infants and preschool children in school age and adolescents. In infants, gastroesophageal reflux, feeding problems, infections include gastroenteritis, respiratory tract otitis media, whooping cough, pertussis, urinary tract, meningitis, food allergy and food intolerance, eosinophilic esophagitis, intestinal obstruction, pyloric stenosis, atresia, duodenal and other sites, intussusception, malrotation, volvulus, duplication cysts, strangulated inguinal hernia, Hirschsprung disease, inborn error of metabolism, congenital adrenal hyperplasia, and renal failure. Preschool children, gastroenteritis infection includes respiratory tract otitis media, urinary tract, meningitis, and whooping cough and pertussis. Appendicitis, intestinal obstruction, intussusception, malrotation, volvulus, adhesions, foreign body like bezoar, raised intracranial pressure, celiac disease, renal failure, inborn error of metabolism, and torsion of the testes. School age and adolescent gastroenteritis, infection including pyelonephritis, septicemia, meningitis, peptic ulceration, and H. pylori infection, appendicitis, migraine, raised intracranial pressure, celiac disease, renal failure, diabetic ketoacidosis, alcohol, drug ingestion, or medication, cyclical vomiting syndrome, bulimia, anorexia nervosa, pregnancy, and torsion of the testes. It is usually benign and is often caused by feeding disorders of mild gastroesophageal reflux or gastroenteritis. Potentially serious disorders need to be excluded if the vomiting is bilious or prolonged, or if the child is systemically unwell or has faltering growth. In infants, vomiting may be associated with infection outside the GIT, especially in the urinary tract and central nervous system. In intestinal obstruction, more proximal the obstruction, the more prominent the vomiting, the sooner it becomes bile stain, unless the obstruction is proximal to the ample obvator. Intestinal obstruction associated with abdominal distension, more marked in distal obstruction. Red flag clinical features just did. And now the summary: vomiting in infants, common chronic cause is gastroesophageal reflux. Feed volumes should be calculated as overfeeding is common in bottle-fed infants. If transient with other symptoms, that is fever, diarrhea, runny nose, and cough, most likely to be gastroenteritis or respiratory tract infection. We'll consider urine infection, sepsis, or meningitis. If projectile at 2 to 8 weeks of age, exclude pyroextenosis and bile stain, potential emergency, exclude intestinal obstruction, especially dissection, malrotation, and strangulating inguinal hernia, assess for dehydration and shock. Gastroesophageal reflux. Gastroesophageal reflux is the involuntary passage of gastric contents into the esophagus. It is extremely common in infancy. It is caused by inappropriate relaxation of the lower esophageal sphincter as a result of functional immaturity, a predominantly fluid diet, a mainly horizontal posture, and a short intra-abdominal length of esophagus all contribute. While common in the first year of life, nearly all symptomatic reflux resolves spontaneously by 12 months of age. This is probably due to combination maturation of the lower esophageal sphincter, assumption of an upright posture, and more solids in the diet. Most infants with GERD, gastroesophageal reflux, have recurrent regurgitation or vomiting, but are putting on weight normally and are otherwise normal, although the mess, smell, and frequent changes of clothes, 5% of those affected have 6 or more episodes each day, is frustrating for parents and carers. Gastroesophageal reflux is usually a benign, self-limited condition, but when it becomes a significant problem, it becomes gastroesophageal reflux disease and needs treatment. Gastroesophageal reflux disease is more common in children with cerebral palsy or other neurodevelopmental disorders. Preterm infants, especially in those with bronchopulmonary dysplasia, following surgery for esophageal atresia or diaphragmatic hernia. Investigation, gastroesophageal reflux is usually diagnosed clinically and no investigations are required. However, they may be indicative the history is atypical, complications are present, or there is failure to respond to treatment. Investigations include 24-hour esophageal pH monitoring to quantify the degree of acid reflux, 24-hour impedance monitoring, which is available in some centers. Weakly acidic or non-acidic reflux, which may cause disease, is also measured. Endoscopy with esophageal biopsy to identify esophagitis and exclude other causes of vomiting. Complication of gastroesophageal reflux, faltering growth from severe vomiting, esophagitis, hematemesis, discomfort on feeding or heartburn, iron deficiency anemia, recurrent pulmonary aspiration, recurrent pneumonia, cough or wheeze, apnea in preterm infants, dystonic neck posture, Sandifer syndrome, and apparent life-threatening events. And now the case history. The infant had a history of frequent regurgitation from the first few days of life. He developed 2 chest infections. Some of the vomits contained altered blood. 24-hour esophageal pH study showed severe gastroesophageal reflux disease. Endoscopy showed esophagitis. He had probably had episodes of aspiration, pneumonia, symptoms resolved in treatment with feed thickeners and omeprazole. His parents also commented on how much better he slept at night. Treatment was reduced from 14 months of age and symptoms did not recur. Which pH sensor has been placed in the lower esophagus. And this is a section of 24-hour esophageal pH study and the section of normal esophageal pH study. Contrast studies of the upper gastroesophageal tract may support the diagnosis but are neither sensitive nor specific. They may be required in gastroesophageal disease to exclude underlying anatomical abnormalities in the esophagus, stomach, and duodenum, and to identify malrotation. Management: uncomplicated gastroesophageal reflux has an excellent prognosis, can be managed by parental reassurance, adding inert thickening agents to feeds, for example, Carabel, and smaller, more frequent feeds. Significant gastroesophageal reflux disease is managed with acid suppression with either hydrogen receptor antagonists, ranitidine, or proton pump inhibitors, or meprazole. These drugs reduce the volume of gastric contents and treat acid-related esophagitis. The evidence for the use of drugs that enhance gastric empty domperidone is poor, and as is associated with significant side effects, their use should be discouraged. If the child fails to respond to these other diagnoses, such as cow's milk protein allergy, should be considered with further investigation performed. Surgical management is reserved for children with complications unresponsive to intensive medical treatment or esophageal stricture. A nascent fundoplication, in which the fundus of the stomach is wrapped around the intra-abdominal esophagus, is performed either as an abdominal or as a lap procedure. Now, the summary: gastroesophageal reflux occurs in otherwise normal infants, but risk is increased if the infant has neuromuscular problems or has had surgery to the esophagus or diaphragm, is treated if troublesome with field thickening, medication, and relief fundoplication. Investigations are performed if diagnosis is unclear or complications occur. Gastroesophageal reflux disease, pyloric stenosis. In pyloric stenosis, there is hypertrophy of the pyloric muscle causing gastric outlet obstruction. It presents at 2 to 8 weeks of age, irrespective of gestational age. It is more common in boys, 4:1, particularly firstborn, and there may be family history, especially on the maternal side. Clinical features are vomiting, with increase in frequency, forcefulness over time, ultimately becoming projectile. Hunger after vomiting until dehydration leads to loss of interest in feeding, weight loss if presentation is delayed. A hypochloremic metabolic alkalosis with a low plasma sodium potassium occurs as a result of vomiting stomach contents. Diagnosis: unless immediate fluid resuscitation is required, test feed is performed. The baby is given a milk feed, which will calm the hungry infant, allowing examination. Gastric peristalsis may be seen as a wave moving from left to right across the abdomen. The pyloric mass, which feels like an olive, is usually palpable in the right upper quadrant. If the stomach is over-distended with air, it will need to be emptied by a nasogastric tube to allow palpation. Ultrasound examination may be helpful to confirm the diagnosis prior to surgery. Management: the initial priority is to correct any fluid and electrolyte disturbances with IV fluids. Once hydration, acid base, and electrolytes are normal, definite treatment by myotomy can be performed. This involves division of the hypertrophied muscle down to but not including the mucosa. The operation can be performed either as an open procedure via a periumbilical incision or laparoscopically. Post-operatively, the child can usually be fed within 6 hours and discharged within 2 days of surgery. Now, the summary: pyloric stenosis is more common in boys and in those with a family history. Signs of visible gastric peristalsis, palpable abdominal mass and test feed, and possible dehydration. Associated with hyponatremia, hypokalemia, and hypochloremic alkalosis. Diagnosis may be confirmed by ultrasound, treated by surgery after dehydration, correction of electrolyte imbalance. The time healthy baby cry is highly variable and most represents a baby's response to hunger and discomfort. Reassurance and advice on appropriate feeding will usually suffice. Some babies cry for prolonged period in spite of feeding and comforting, and this is distressing for all concerned. It can engender a feeling of anxiety, helplessness, and depression in parents and carers, particularly if they're inexperienced or poorly supported. It has also been suggested that the emotional climate within a home may be transmitted to a baby, and that in some instances, tense, anxious, or irritable caregivers are more likely to have fretful babies. The complaint that a baby is always crying may also be a pointer to potential or actual non-accidental injury. A cause for the crying is identified in a minority of infants, if of sudden onset, may be due to a urinary tract, middle ear, or meningeal infection. Pain from an unrecognized fracture, esophagitis, or torsion of the testes. Severe napitasm constipation may with a miserable crying infant. Preterm infants who have spent several weeks in hospital can be difficult to settle, as can infants with a chronic neurological disorder, cerebral palsy. On a basis of countless reports of parents, eruption of teeth is painful in some infants. However, teething does not cause vomiting, diarrhea, high fever, or seizures. Acknowledging that troublesome crying is extremely distressing is part of the management. Reducing overstimulation from jigging and winning, encouraging quiet environment, and holding the baby close until the crying stops appears to help many babies. Parental support through follow-up by health professionals is helpful. Infant colic. The term colic is used to describe a common symptom complex that occurs during the first few months of life. Paroxysmal inconsolable crying, screaming after accompanied by drawing up of knees and passage of excessive flightus takes place several times a day. There is no firm evidence that the cause is gastrointestinal, but this is often suspected. The condition occurs in up to 40% of babies, typically occurs in the first few weeks of life and resolve gradually from 3 to 12 months of age. The condition is benign, but is very frustrating, worrying for parents, and may precipitate non-accidental injury in infants already at risk. Support and reassurance should be given. Gripe water is often recommended, but is of unproven benefit. Is severe and persistent, may be due to cow's milk protein allergy, and an empirical 2-week trial for protein hydrolysate formula cow's milk protein free may be considered and continued if symptoms improve. If they do not, then trial of gastroesophageal reflux treatment may be considered. Now the picture showing the pyloric stenosis. Number A is showing the visible gastric peristalsis in infant with pyloric stenosis. Diagram showing a test feed being performed to diagnose pyloric stenosis. Pyloric mass feels like an olive on gentle deep palpation halfway between midpoint and anterior margin of the right rib cage and the umbilicus. The ultrasound examination showing gastric incontinence in the antrum and elongated pylorus. Dotted lines. The pyloric stenosis at operation showing real thick pyloric muscle and pyloromyotomy incision. Now, acute abdominal pain. Assessment of the child with acute abdominal pain requires considerable skill. The differential diagnosis of acute abdominal pain in children is semi-wide, encompassing non-specific abdominal pain, surgical causes, and medical conditions. In nearly half of the children admitted to hospital, the pain resolves undiagnosed. In young children, it is essential not to delay the diagnosis and treatment of acute appendicitis as progression to perforation can be rapid. It is easy to belittle the clinical signs of abdominal tenderness in young children. Of the surgical causes, appendicitis is by far the most common. Testes, hernial orifices, and hip joint must also be checked. It is noteworthy that lower lobe pneumonia may cause pain referred to the abdomen. Primary peritonitis is seen in patients with ascites from nephrotic syndrome or liver disease. Diabetic ketoacidosis may cause severe abdominal pain. Urinary tract infection, including acute pyelonephritis, is a relatively uncommon cause of acute abdominal pain, but must not be missed. It is important to test a urine sample, not identify not only diabetes mellitus, also condition affecting liver and urinary tract. Pancreatitis may present with acute abdominal pain, and serum amylase should be checked. Now, the causes of acute abdominal pain: surgical, intra-abdominal, either surgical or medical, surgical acute appendicitis, intestinal dysfunction, including intussusception, inguinal hernia, peritonitis, inflamed microdiverticulum, pancreatitis, and trauma. All are surgical and non-medical. Non-specific abdominal pain, gastroenteritis, urinary tract infection, acute pyelonephritis, and hydronephrosis, renal calculus, henoch purpura, diabetic ketoacidosis, sickle cell disease, hepatitis, inflammatory bowel disease, constipation, recurrent abdominal pain of childhood, gynecological and pubertal females, psychological, lead poisoning, acute porphyria, rare and unknown, extra abdominal, upper respiratory tract infection, lower lobe pneumonia, torsion of testes and hip and spine. Now, acute appendicitis. Acute appendicitis is the most common cause of abdominal pain in childhood requiring surgical intervention. Although it may occur at any age, it is very uncommon in children under 3 years of age. The clinical features of acute uncomplicated appendicitis are symptoms: anorexia, vomiting, abdominal pain, initially central and colicky, appendicular, midgut, colic, and then localizing to the right iliac fossa from localized peritoneal inflammation. Signs are fever, abdominal pain aggravated by movement, for example, on walking, coughing, jumping, bumps on the road during a car journey, persistent tenderness with guarding in the right iliac fossa, McBurney's point. However, with a retrocecal appendix, localized guarding may be absent, and in a pelvic appendix, there may be few abdominal signs. In preschool, children's diagnosis is more difficult, particularly early in the disease. Fecal lids are more common and can be seen on the plain abdominal X-ray. Perforation may be rapid as momentum is less well developed and fails to surround the appendix, and the signs are easy to underestimate at this stage. Appendicitis is a progressive condition, so repeated observation and clinical review every few hours are key to making the correct diagnosis. Avoiding delay on one hand and unnecessary laparotomy on the other. No laboratory infection in investigation or imaging is consistently helpful in making the diagnosis. A neutrophilia is not always present on full blood count. White blood cells organisms in urine are not uncommon in appendicitis, as inflamed appendix may be adjacent to ureter or bladder. Although ultrasound is no substitute for regular clinical review, it may support the clinical diagnosis. Thickened non-compressible appendix with increased blood flow and demonstrate associated complications such as an abscess, perforation, or an appendix mass, and may include other pathologies causing symptoms. In some centers, laparoscopy is available to see whether or not the appendix is inflamed. Appendectomy is straightforward in uncomplicated appendicitis. Complicated appendicitis include the presence of an appendix mass, an abscess, or perforation. If there is generalized scarring consistent with perforation, fluid resuscitation and intravenous antibiotics are given prior to laparotomy. If there is a palpable mass in the right iliac fossa and there are no signs of generalized peritonitis, it may be reasonable to elect for conservative management of intravenous antibiotics with appendectomy being performed after several weeks. If symptoms progress, laparotomy is indicated. Non-specific abdominal pain and mesenteric adenitis. Non-specific abdominal pain is abdominal pain which resolves in 24 to 48 hours. The pain is less severe than in appendicitis, and tenderness in the right iliac fossa is variable. It is often accompanied by an upper respiratory tract infection with cervical lymphadenopathy. In some of these children, the abdominal signs do not resolve and appendectomy is performed. Mesenteric adenitis is often diagnosed in those children in whom large mesenteric nodes are seen at laparoscopy and whose appendix is normal. But there are doubts whether this condition truly exists as a diagnostic entity. Intussusception describes the invagination of proximal bowel into a distal segment. It most commonly involves ileum passing into the cecum through the ileocecal valve. Intussusception is the most common cause of intestinal obstruction in infants. After the neonatal period, although it may occur at any age, the age of presentation is 3 months to 2 years of age. The most serious complication is stretching and constriction of the mesentery, resulting in venous obstruction, causing engorgement and bleeding from the bowel mucosa, fluid loss, and subsequently bowel perforation, peritonitis, and gut necrosis. Prompt diagnosis, immediate fluid resuscitation, urgent reduction of the intussusception are essential to avoid complications. Presentations typically with paroxysmal severe colicky pain with pallor during episodes of pain. The child becomes pale, especially around the mouth, and draws up the legs. There is recovery between the painful episode, but subsequently the child may become increasingly lethargic, may refuse feeds, may vomit, which may become bile stain depending on the site of the intussusception. A sausage-shaped mass, often palpable in the abdomen, passage of a characteristic red currant jelly stool comprising bloodstained mucus. This is a characteristic sign, but tends to occur later in the illness and may be first seen after rectal examination, abdominal distension, and shock. Usually, no underlying intestinal cause for the intussusception is found, although there is some evidence that viral infection leads to enlargement of Mrcpch may form the lead point of the intussusception, and identifiable lead points such as the Michael-Davison polyp is more likely to be present in children over 2 years of age. Intravenous fluid resuscitation is likely to be required immediately, as there is often pooling of fluid in the gut, which may lead to hypovolemic shock. Now, intussusception showing why the blood supply to the gut rapidly becomes compromised, making relief of this form of obstruction urgent. Child with an intussusception. The mass can be seen in the upper abdomen. The child has become shocked. An abdominal X-ray demonstrating an intussusception with contrast, and the reception operation showing the ileum entering the cecum. The surgeon squeezing the colon to reduce intussusception. Next of the abdomen may show distended small bowel and absence of gas in the distal colonorectum. Sometimes the outline of the intussusception itself can be visualized. Abdominal ultrasound is helpful both to confirm the diagnosis, the so-called target donut sign, and to check response to treatment. Unless there are signs of peritonitis, reduction of the intussusception by rectal layer insufflation is usually attempted by radiologists. This procedure should only be carried out once the child has been resuscitated and under the supervision of a pediatric surgeon. In case the procedure is unsuccessful or bowel perforation occurs. Success rate of this procedure about 75%. When 25 requires operative reduction. Recurrence of the intussusception occurs in less than 5%, but it is more frequent after hydrostatic reduction. Now, the summary: intussusception usually occurs between 3 months and 2 years of age. Clinical features of paroxysmal colicky pain with pale abdominal mass and red currant jelly stool. Shock is an important complication, requires urgent treatment. Reduction is attempted by rectal air insufflation. Unless peritonitis is present, surgery is required if reduction of the air is unsuccessful or for peritonitis. This is the technetium scan showing uptake of ectopic gastric mucosa and a medical diverticulum in the right iliac fossa. The medical diverticulum is around 2% original, have an ileal remnant of the vitilo intestinal duct, a medical diverticulum which contains ectopic gastric tissue or pancreatic tissue. Most are asymptomatic, but they may present with severe rectal bleeding, which is classically neither bright red nor true melena. There is usually an acute reduction in hemoglobin. Other forms of presentation include intussusception, volvulus, twisting of the bowel, or diverticulitis when inflammation of a diverticulum mimics appendicitis. A technetium scan, which demonstrate increased uptake by ectopic gastric mucosa in 70% of cases. Treatment is by surgical resection. Summary occurs in 2% of individual journey asymptomatic but may present with bleeding, may be life-threatening or interception or volvulus. Treatment is by surgical resection. Now, malrotation during rotation of the spinal cord of fetal life, if the mesentery is not fixed at the internojejunal flexure or in the ileocecal region, its base is shorter than normal and is predisposed to volvulus. Lad bands, peridural bands that may cross the duodenum, often anteriorly. There are two presentations: obstruction with the compromised blood supply, obstruction with bilious. Vomiting is the usual presentation in the first few days of life, but can be seen at a later age. Any child with dark green vomiting needs an urgent upper gastrointestinal contrast study to assess intestinal irritation unless signs of vascular compromise are present. When an urgent laparotomy is needed, this is a surgical emergency, as when a volvulus occurs, the superior mesenteric arterial blood supply to small intestine and proximal large intestine is compromised, and unless it is corrected with will lead to infarction of these areas. And at operation, the volvulus is untwisted, the ureter mobilized, and the bowel placed in the non-rotated position with the duodenal jejunal flexion on the right and cecum appendix on the left. The malrotation is not corrected, but the mesentery broadened. Appendix is generally removed to avoid diagnostic confusion should the child subsequently have symptoms suggestive of appendicitis. Summary: malnutrition, uncommon but important to diagnose, usually presents in the first 1 to 3 days of life. Intestinal obstruction from lad bands, obstruction duodenum volvulus, may present at any age, but volvulus causing obstruction in ischemic bowel. Clinical features are bilious vomiting, abdominal pain, tenderness from peritonitis or ischemic bowel. An urgent upper GI contrast is indicated if there is bilious vomiting. Treatment is urgent surgical correction.